Good morning, everyone. This is Olivia Marquez, and I'm a research coordinator with Health Evidence. It is my pleasure today to welcome you to our monthly webinar series. Today, we will be discussing school-based interventions to prevent HIV, STIs, and adolescent pregnancy. What's the evidence? So throughout the session today, we will be posting some polling questions through WebEx. And your participation in the polling questions is voluntary and anonymous. We hope that we can help stimulate and enable engagement and discussion throughout the session. So I'll leave this slide up for just a moment about your consent. All right, so just to let everyone know that after today, the PowerPoint presentation and the audio recording will be made available through Health Evidence's YouTube and SlideShare account. So we'll try and make sure those resources are available within the next week. And the links to our SlideShare account and YouTube account will be posted in the chat section. So today we're very excited to be talking about this Cochrane review. So the review was published in 2016, and we do have the links available to the Health Evidence dedicated review page and links to the full text. So we invite you and welcome you to click on the full text link, and you can follow along with the systematic review as Amanda presents today. So just a few housekeeping items before we get started. We ask you to please post your comments or questions in the chat section on WebEx. And we ask that you send your questions along to all the participants and not just to the host, so we can make sure that everyone can see your questions or comments. If you do, not a problem, we will still see them. So towards the end of the session, we'll have a dedicated question and answer session where I can read your questions aloud to our presenter as we go through our Q&A section. You don't need to wait until the end of the session. We invite you to still post questions as we're going through, and I can raise those at the end. For any connection issues that you have today, we invite you to please contact the WebEx 24/7 helpline. So that number is there on the slides, and we'll make sure that's included in the chat section as well. For your audio, you can navigate to the top of WebEx and click on Communicate and then Audio Broadcast, and then you can listen through your computer speakers. So our first polling question today, we're wondering how many people are listening to today's session with you. So we'll open up that poll question within WebEx, and you can click your response and then just make sure you hit Submit. So thank you to those who are responding. So we see quite a few people are joining just themselves, and we have a few people who are joining with a small group of 2 or 3 individuals. So that's great to see people who are connecting with other individuals. So this is just a slide here to give you an idea of our Health Evidence team. There's quite a few of us who are involved here with helping to coordinate the monthly webinar series and to make sure that our registry is maintained and up to date. So we give thanks and credit to those who are involved in our team. So for those of you who may not be familiar, Health Evidence launched in 2005, and we are a comprehensive registry of reviews evaluating the effectiveness of public health and health promotion interventions. We provide over 90,000 visitors per year, access to over 5,000 quality-rated systematic reviews. So one of our main goals of Health Evidence, in addition to making health evidence on the effectiveness of public health interventions more accessible, is to make it easier for professionals to use the evidence in decision-making. So the value added for Health Evidence is that we save you time. We have done the work to screen and appraise each review within our registry. We screen all reviews for relevance to public health and keep our registry up to date by constantly screening relevant databases. So at any given time, we're about no more than 1 to 2 months behind the publication dates. We've done the work for you by critically appraising all the reviews and we use a transparent process whereby you can actually click on the full quality assessment for each review and see how we've rated that review based on our 10 assessment criteria. So healthevidence.org has various other tools and supports for evidence-informed decision-making on our website. And many users over the years have informed us that our tools and repository are easy and simple to use. So here I'll just keep this slide up for a moment, and this is a model of evidence-informed decision-making in public health, which consists of 5 components that you can see in this diagram. So traditionally, public health practitioners and decision makers consider evidence about community health issues and local context, existing resources, and community and political climate when making decisions about programs and policies. However, it's become more apparent that considering research evidence may be more challenging. So as such, the Health Evidence webinar series is designed to identify research evidence relevant to public health decisions and present this to you through this forum. So the evidence-informed public health wheel illustrates how these steps are involved with evidence-informed practice. So the wheel is a guide for practitioners and decision makers to determine how to address a particular issue by systematically incorporating research evidence in the decision-making process. So there's 7 steps in this wheel, and today we're going to be hearing about how our presenter has worked through the first 4 steps in order to help with the decision makers with the remainder of the 7 steps. So before we move on, we're just going to open our second polling question, and we're wondering how many of you have heard or are familiar with the PICO-S. So again, we invite you to respond on WebEx and make sure to hit submit. So thank you to those who are responding. We're seeing we're about quite a few bit more are not familiar with PICO-S, and a few of you are familiar. So thank you to those who are responding. It's great to see kind of the range of our audience. So just to kind of review PICO-S before we hear from our presenter. PICO is a way for you to structure your questions in a defined set of evidence-informed decision-making. It involves defining who the population is that you're interested in, what the intervention is that you may want to know about, or program or service, the comparison group, if any, and the specific outcomes that you're looking for. Sometimes we also might have a particular setting in mind, so this can be school or community settings, for example. So the value added of using a PICO question is that when you have an issue that arises, you can use PICO to turn this into a searchable question, which allows you to further articulate specific components of the question and helps you to hone in so that when you search for evidence, you will find it much more quick and easy. So with that, we have just our last polling question before we hear from our presenter, and we're wondering how many of you use systematic reviews to inform a program or service? So again, we'll just leave that open for a few moments. We're seeing a few people who sometimes or often use systematic reviews, which is really great to see. A few have never used systematic reviews. And if you're not familiar with what a systematic review is, hopefully today will help to kind of enlighten that process for you. So we'll leave that open for just a moment longer, and thank you to those who are responding. With that, I would like to formally introduce our presenter today, Dr. Amanda Mason-Jones, and we're so thrilled to have her present on this Cochrane review, which I know a lot of our audience is interested in, and we've drawn quite a large audience today. So without further ado, I'd like to introduce Dr. Amanda Mason-Jones. So thank you for joining us today, Amanda, and I'll pass the ball to you to present.
Thank you. Can you hear me okay?
Sound great.
Excellent. Okay. Welcome, everybody, and thanks for joining. So I'm going to talk through a Cochrane review and meta-analysis that was published in November 2016. Just trying to see whether I can, okay. So I just want to begin by acknowledging the team from the UK and South Africa that included colleagues from a number of organisations and from a range of multidisciplinary backgrounds, including medicine, social work, psychology, nursing, and biostatistics. This review was unfunded, but the employers of the team supported the review. So I just wanted to acknowledge that support up front. Also, a review like this benefits from support throughout the process. And I just wanted to acknowledge further some other people. So Joy Oliver, who is based at the South African Cochrane Centre, designed the search strategy. Paul Garner and Anne-Marie Stephanie supported the review going to publication. Haskell Horvath supported the early days of the review. Alan Flischer and Wanjiro Mukoma wrote the original protocol. And Jimmy Volming suggested the focus on biological outcomes, which we're going to pick up a bit later. So the review has had a lot of attention and is currently in the top 97th percentile for research outputs. And this is probably because it's both an important issue, but also quite a divisive issue. That has been picked up by scientific media, those who have also focused on the need for improved approaches to sexuality and relationship education, and others who have focused on the failure of sexuality education or have slightly misrepresented the review. And so today I want to outline the review, so hopefully the message will be clearer, and we'll go through it step by step in the hope that you get that clarity. So this was the research question. Can school-based sexual and reproductive health programs reduce sexually transmitted infections such as HIV, herpes simplex virus, and syphilis, and pregnancy among adolescents? So why were we asking this question? So as many of you will know, adolescents have an important place in the post-2015 development agenda, and 3 of the United Nations Sustainable Development Goals specifically target them and their sexual and reproductive health and their access to appropriate health services as a human right. Young people remain a high-risk group who are less likely to have access to services, and incident HIV infections among people aged 15 to 24 years have been increasing since 2000. Adolescents in the African region had 90% of HIV-related deaths. And also, despite a downward trend in adolescent pregnancy worldwide, most pregnancies in girls under the age of 18 are unwanted, and many are terminated. This can be compounded by restrictive abortion laws and lack of services, and can result in high levels of maternal mortality. If pregnancies are continued and unwanted, this is associated with adverse outcomes for both the mother and infant health. So prevention is really important. We talked earlier about the PICO-S. In this, for the S, I've used study design, but we'll just go through this. So the inclusion was, the population, was adolescents 10 to 19 attending school. The intervention was any intervention that aimed to reduce the risk of HIV, STIs, and pregnancy. The comparison was usual practice or some other intervention. And the outcomes here are very important. So we've decided on biological outcomes, and I'll explain that a little bit more. So in the early scoping work, we realized that there were already a lot of reviews on this topic and a number of randomized control trials, but they all used self-reported behavioral outcomes. So they asked young people whether they used condoms, whether they delayed having sex, whether they had been tested for an STI. But these reports are often prone to bias. There's also been a concern that if you just measure changes in knowledge or attitudes and self-reported behavior, you may stop short of achieving the endpoints that we're actually trying to achieve in public health. So that's why the biological outcomes were measured in this way. And the study design that we included were randomized controlled trials only. We set about searching these databases, and as I mentioned previously, Joy Oliver at the South African Cochrane Centre designed the searches. And this one word of advice, I would say, is that it's invaluable to have a specialist designing your search strategies, because then you get a search which is not only comprehensive but also quite focused as well. So that's so these were the databases we searched. The searches were reviewed independently by at least 2 review authors, who then came together to compare the papers that were highlighted. And if in doubt, we included those studies. We wanted to be inclusive, basically. We were quite keen that we did not miss anything. And from this, we obtained the final full text article from the first screening. And at that point, we decided whether it should be included or not. And this process also, what emerged were some new and ongoing studies that were also identified. We designed a data extraction sheet to collect the detailed information about each study. If we weren't clear about something, we looked at the supporting papers. So, for example, many randomized controlled trials will have baseline or intervention development publications. But all of this was put into one data extraction sheet. And this became a very detailed repository of information for us. The results from each of the studies was also extracted. We designed an Excel spreadsheet to calculate the log of the risk ratio, which is used to calculate the risk ratio using a random effects model. The design effect and intra-class correlation coefficient refers to the clustered nature of the data. So people in one school, in one community, in one area can be similar in some ways. So this adjustment addresses for this issue in the analysis. Again, just a note that multiple interventions in one trial were analysed separately. So this was only of relevance to one trial in Kenya, which had 3 interventions, one of which was an educational intervention, one was incentive-based, and one combined both education and incentives together. It's also important to look at the quality and the risk of bias in each of the studies. And for that, we used the GRADE approach to assess the quality of the evidence and the Cochrane risk of bias assessment tool for cluster randomized controlled trials. We had a very focused search, and from 1,183 unique references after the duplicates were removed, we actually ended up with only 8 cluster randomized controlled trials. And we actually had to, we screened 71 full text articles, but excluded most of them. This is the Prisma flow diagram, which shows the process that we went through. So this is just a diagrammatic representation of the process. And this is also in the review if you want to refer back to this. Just a quick note about the excluded studies and the reasons for exclusion. So this was after the full text articles were read and searched through. So the reasons for exclusion were that 26 had no biological outcomes, 10 were not school-based, 12 weren't randomized control trials, 11 were systematic reviews, and 4 were protocols or early reports. When it comes to the included studies, we found 8 cluster randomized control trials, which were from a range of countries. 281 clusters were part of these studies. So the clusters were either schools or communities or administrative areas. And the size of the clusters, so that means the number of people in each school or each community, was between 18 and 461 people, and the total number of participants involved in all of the trials together was over 55,000. The studies also had a relatively long follow-up. So the shortest was 18 months and the longest follow-up was 7 years. We found quite specific types of intervention. So these were educational, which were generally curriculum-based with additional aspects, which included training teachers, parents, or local health service providers, and incentives, which were largely to encourage school attendance, or combined incentive and educational interventions. The theoretical frameworks generally that supported the educational interventions were based on psychological theories of change. They varied in intensity, so from between 3 hours to 24 hours in total. And the people who delivered the programs were either peer educators or adults, including teachers, and they used a range of delivery approaches. This is what the assumed logic model might look like for this kind of approach. So there's certain influencing factors which lead to knowledge, attitudes, and behaviors, and then lead to the final impact. The other type of intervention was more focused on upstream factors. So they saw school as a kind of social vaccine, and so they encouraged young people to stay at school. So the incentives that were given were sort of cash for the participant and for the family, or some other kind of material transfer. In the case of the Kenyan study, this was school uniforms. And these could be either conditional on school attendance or unconditional. Human immunodeficiency virus, herpes simplex 2, and other sexually transmitted infections were measured by dried blood spots, blood sera during urine tests, and basically pregnancy was also measured by urine tests, and pregnancy at long-term follow-up was measured by linkage to health service records or school reports. So we undertook 3 main comparisons. So we compared educational interventions versus no intervention, incentive programs versus no intervention, and educational interventions and incentive programs versus no intervention. Here's one of the first comparisons for one outcome, which is HSV2, herpes simplex virus 2. It's showing for young women and young men separately and for all of them combined. So rather than looking at the detail, I want you to instead look at the central line, which is labeled risk ratio. And at the bottom of that line, on the right, it says favors control, and on the left, it favors intervention. So you're looking to see whether the intervention works or not. If the intervention works, you would see that the dots on this line would move to the left. And as you can see, there's no difference in effect. If you look at educational interventions in pregnancy, you'll see a similar looking table. Here, if you look at the incentive-based programs, you can see that there are only 2 studies, and that again, similar results. Although the Baird study, which is the one at the top, looks promising. So that's a study that was conducted in Malawi. Just a note, although we did focus on biological outcomes, we also included self-reported outcomes as secondary outcome measures. And we can see that the incentive-based programs did seem to show a delay in self-reported sexual debut. In terms of incentives and pregnancy, there were only 2 studies, and it did show that the intervention was potentially effective in reducing pregnancy. If we look at the combination of incentive plus education, it was only 1 study, so we can't really do much with that, but again, potentially promising. We also have to take into account not only the results, but also the risk of bias. As I mentioned before, the studies on the whole were well conducted, and in this table you can see the green shows a low risk of bias, and the red a high risk of bias. The yellow was unclear, and we used the Cochrane risk of bias tool for this. When we look specifically at the included studies and their risk of bias, you can see one study that stands out, and this is the Cabazon study, which was conducted in Chile. So it's the second study down, so it has a lot of red. And if we look at this table, we can see how this study could easily mislead. So comparing educational interventions versus no interventions for the long-term pregnancy prevalence. This study has very small numbers, is clearly very different to the other studies in some way, and we also know that the risk of bias is very high. So really we need to be cautious about accepting the results of this study. So the risk of bias, these are the things that you have to go through to conduct a risk of bias assessment, and it looks in great detail how the study was conducted. The grade approach also shows how certain we are about the results, so high certainty to very low certainty. So it depends on how certain we are, whether the more research needs to be done. Okay. And we can see, again, this is quite a conservative approach. So in terms of educational interventions, we have low to moderate certainty. So again, we still need more research. In terms of the incentive-based programs, if you look at the right-hand side of the table here, we have low and very low certainty. So again, certainly we need more evidence in this area. So the trials that evaluated educational interventions incorporated many of the specific characteristics that have been recommended for well-designed adolescent sexual and reproductive health interventions, but they were still not able to show an effect on the main outcomes. Some of the trials were underpowered to detect HIV because even in geographical settings where HIV is more common than elsewhere, the incidence during adolescence is relatively low and very large trials would be needed to exclude small effects. Of the more common outcomes, such as HSV2 and pregnancy, the trials are adequately powered to detect the effects, and if the interventions are not reducing these more common outcomes, they're unlikely to be having an effect on HIV. So a lot of effort went into designing many of these educational programs, and they still may have failed to address some of the issues and the areas that might be critical to change. It was unclear, for example, to what extent programs incorporated discussions of exploitation or violence in relationships, or whether the messages were adapted appropriately for both males and females. What we do know is that none of the programs gave condoms freely to participants, and only 2 of the educational programs, or any of the programs actually demonstrated condoms to young people. So therefore, it's not possible to say educational programs would never work, only that these programs did not work despite extensive efforts to develop approaches through consulting with young people themselves. The other possibility is that educational programs alone don't address wider structural issues that influence sexual health outcomes, sexual behavior, and risk-taking. The availability and affordability of schools and health services, contraceptive choices and condoms, poverty, and cultural gender norms. So this is why many have started to develop and promote interventions which prioritize school attendance and educational achievement. The review included these 2 trials that promoted school attendance through cash transfers and giving away free school uniforms, and further trials are underway to explore this. But these 2 early trials had positive but conflicting findings, so we should still remain cautious about this approach. We only used peer-reviewed trials in this systematic review, so published peer-reviewed evidence. We feel that it's unlikely that we missed anything that was unpublished that included biological outcomes, because this is a relatively new innovation in adolescent sexual and reproductive health research. So as mentioned, we did not include before and after studies, which are often used in public health interventions. And we decided to exclude these kind of studies with less robust designs because we felt that they were unlikely to add anything further. The conclusions are consistent with previous published reviews of curriculum-based educational programs. And there certainly seems to be a consensus that in sub-Saharan Africa, few curriculum-based programs have been effective. And also, unfortunately, many of them have a high risk of bias. There is some early evidence that incentive-based programs that encourage school attendance may reduce pregnancy in adolescents, and this is also confirmed by observational studies. Excuse me. There are currently 5 ongoing studies, 4 cluster randomized controlled trials, and 1 which is an individually randomized study. 3 are being conducted in South Africa, 1 is incentive only, 1 is education only, and 1 is incentive plus education. There's also an educational intervention being conducted in Botswana and also in India. So to conclude, does this mean that we shouldn't provide sexual health and relationship advice to young people in schools? I would say emphatically no. This information and appropriate services should be made available to young people still. What we don't know is exactly what works and why. So we need to expand our logic model, as it is probably insufficient at the moment. We also need to expand and adapt our theoretical approaches in line with this. These educational interventions were between 3 and 26 hours long in total. This just may not be enough, and it may be delivered too late in the school career of the young people. The other thing to think about is longer-term follow-up. So these studies, many of them did follow up longer term. So in terms of research, long-term follow-up is important for research studies. And finally, biological outcome measures are also really important. And I would really stress that other researchers consider this when they're setting up trials in the future. Okay, thank you for listening, and I'm very happy to take questions.
Thank you very much, Amanda. That was a great overview of your Cochrane review, and interesting to see the results and hear a little bit of your side as to how we should, you know, interpret or actually use this evidence in practice, because I think that's one of the key points that sometimes gets misinterpreted. So that was really great to see. So thank you for presenting today. We'll now invite attendees to post questions in the chat section, and I can read those aloud to our presenter. So I see one question that's coming in first, asking if you have any insight into why the research is lacking in North America.
I don't actually, no. No, I don't have any insight. I mean, there are quite a number of randomized controlled trials in North America. What is lacking are those that measure biological outcomes. So there are a lot of studies that measure self-reported outcomes. So that's why they haven't been included in this particular review.
That's interesting, and correct me if I'm wrong, you had two studies included in your review that were from the UK.
Yes, yeah, one from Scotland and one from England, yeah.
Okay, so are you aware of any sort of policy action that has been taken to make sure that researchers are including these biological outcomes in future studies?
No, but I mean, maybe it's to do maybe in the UK, because the National Health Service, the NHS, has data available where you can actually track people. That's what made that possible. So the study, basically they followed up young people into their sort of early 20s using data from the NHS. So we have that ability. So I suppose health systems that have that ability to track young people longer term, you know, this kind of research is much easier. If you have very disparate or, you know, providers of health services and no linkage of data, then that makes it more problematic, more difficult.
That's great. Definitely interesting to hear. So we have another question that I think pertains to the incentive studies. So the question is, who or which organizations are providing the incentives? Is this government or school or public health?
Okay, so the incentive was provided in, I mean, all of these studies, it was provided in the context of the study. So it was an experimental study, that the incentive was specifically being tested in the study. So it wasn't being provided as a normal kind of everyday intervention. This was something that was specifically being tested in the context of the trial. Is that clear? So and so the funders, so in terms of, one was funded by the World Bank, the other I'm not quite sure who it was funded by, but basically they provided funding for the interventions. Yeah.
That's great. Thank you for clarifying. So we have another kind of broad question, and maybe this is encompassing some of the points that you made towards the end. But the question is, so going forward as a practitioner in a school-based program in New Brunswick, Canada, where would one go next with regards to the reduction of STIs and pregnancies?
Yeah, that's a really good question. You know, I think this is a question we're all asking, and so this is a program that's already running. Is that the question? So there's a program already running in schools. Yeah.
That's correct. From the question, it seems like this is a program already in process.
Yeah. So, I mean, I think one of the things that seems to be missing is qualitative work with young people. So interviewing young people, you know, getting them into focus groups, finding out the context within which they have their relationships, their experience of the programs that are being delivered, what they feel like they need, you know, what's missing. So really to go back to young people and find out whether the program is actually meeting their needs or how it might be adapted or changed to meet their needs better. So if you're currently running a program, it's really worth sort of having that more engagement with young people. And then also, you know, there may be, you know, so there may also be excellent programs out there that are being delivered and, you know, may be effective. The reason they're not included in this review is because we only included studies that used a randomized trial design. So if you feel like you've got a really, really good program, it's really worth pairing up with colleagues, you know, who can help to test the intervention in a robust way, and, you know, and share that knowledge with colleagues.
That's great. Thank you. So we have another question here asking, so while you were reviewing the studies that were to be included in the review, were there any studies evaluating the effectiveness of sexual education or incentives on sexual assault rates?
Okay, so we did not include sexual assault as an outcome, and no, none of the studies that were included actually included sexual violence in any of the secondary outcomes either. So unfortunately, I mean, I suppose that's another thing to sort of consider, is that when you're designing studies like this, that you also look at the whole gamut of potential outcomes as well. So you know, it'd be useful to, again, consider a wider range of outcomes when you're doing studies like this. So none of the included studies included sexual assault as a primary or secondary outcome.
That's interesting. Maybe another review.
Yeah.
So another question about the systematic review. So asking if any of the interventions were delivered by teachers or public health professionals or peers. So
yes, they were, yes. So if you look in the review itself, there's a table, I'm just trying to find it now, which actually outlines exactly what each of the, so who delivered each of the studies. So if you just give me a moment, if anybody can find it before me, that would be helpful. Yeah, so some were delivered by teachers, some were delivered by peer educators. Okay, let's see. So the Cabathon study, so delivered by teachers. The Cowan study, delivered by peer educators. Dufflo, so the Kenyan study, delivered by teachers. Henderson, which was the Scottish study, was delivered by teachers. The South African study, GEMET, was adult facilitators, so the people who'd been trained but were adults. The Ross study, teachers and peer assistants. And the Stevenson study was peers only. Yeah. A range of delivery sort of options, yeah.
Certainly, that's great. Thank you for clarifying. So another interesting question from a participant who had asked that in Northern Ontario, in Canada, the residents of remote communities do not really do sexual health education. So how can we realistically get the leaders of the communities to see that a program could be created to meet the needs of the youth if the existing programs don't really work to prevent high rates of STIs?
Can you just repeat the question, please?
For sure. So I think it's kind of relating to getting buy-in from communities.
Oh, yeah.
So how do you get leaders of communities in remote communities to see that a program can be created, a program or an intervention such as this one, to meet the needs of youth if the existing programs aren't really working to prevent high rates of STIs?
Okay. So, yeah, so this is definitely I mean, as I say, it's such a divisive issue, a concerning issue, and I think that buy-in and that very, very important sort of first step is actually understanding the context. So the context where these programs take place, the social norms, the values, the setup is really, really important to understand. It's not easy to just find a program, even that works somewhere else, and transplant it into another place. So I think getting community leaders on board, you know, really doing some in-depth focus group work, some qualitative work, interviews with parents, with community leaders, you know, finding out, getting them to problem solve, you know, what is the problem? If the problem is early unwanted pregnancy, if the problem is STIs, what are the local solutions? And work from there. I think that's the best way to go. So start from where that community is at, and go forward, and make sure that you publish, that you share that information with all of us. So we're all struggling with the same issues in different places.
Definitely, that's great. Definitely getting individuals to share their results and sharing what is effective and what's not effective. That's a very important point. So just another question next here we have, if you noticed any significant differences or any differences in results based on who delivered the intervention.
Yeah, so unfortunately, because we had so few trials, actually, we're not really able to look in detail at the delivery mechanism. That might be something that we could do in future reviews. So, you know, as with Cochrane reviews, you update them as you get more studies in. So because we've got 5 more studies, hopefully, that are going to be able to be included in the future, we may have the possibility then of doing those comparisons to see whether teachers or peer educators might be more effective, or you know, other approaches. So we couldn't do that with this because there were so few studies, unfortunately.
Definitely, that's great, and hopefully as more information comes out, then we can refer back and help that to inform decisions, so that's great.
Yeah.
So another question come in here is if you can speak more about the decision about not including case control or cohort designs. Do you have any plans to explore the research that includes these study designs?
We don't, no. I mean, it would normally be before and after studies that might be included. So a cohort design would just be a longitudinal design. And case control, you can't often see what's really going on. So the idea of including randomized control trials only was really to use the most robust sort of gold standard design. It could be in future that we might consider it. So, I mean, watch this space. It might be, I mean, if people, I mean, they can also write to me offline if anybody is interested in sort of making suggestions for improvements to the review in the future. I'm keen to hear about any ideas. So always open to suggestions and to hear about studies that, you know, people think that we've missed anything out. Also just get in touch. But it could be that we could include other designs. It might be something we do in the future. Yeah, but I think also we would probably need to be funded for that. That's the other thing, because we weren't funded. This was all done sort of in the spare time and weekends, and so it's not so easy to include so many studies and do the analysis. It takes a long time. So.
Certainly, that's a key point of commenting on the review, which is funding, which is always an issue.
Yeah.
or a point to be discussed, so that's great. So I'm not seeing too many more questions, but I do invite attendees to continue to post any questions that they have, and then we can discuss those. And in the meantime, I'll just bring us back to the model for evidence-informed decision-making that we had discussed prior to Amanda's presentation. So as we've seen today, we've really kind of brought to light that research component, and definitely highlighting the fact that, you know, this research component doesn't stand alone. It's within this model of evidence-informed decision-making. So using this evidence in light of other contexts, so community and local issues or community and political preferences, and your other public health resources. And of course, your public health expertise, that is kind of the overlying component of this model. So thank you very much, Amanda, for bringing that to light. And I'll just leave poll question number 4 open. So we're wondering if, you know, if you found the information today useful or helpful to you. So I'll just leave that polling question open for you to respond. And in the meantime, I'll just put up our health evidence slide, which is, you know, a few of you may be wondering what you can do now after we hear about the evidence. So we invite you to visit our website, again, where we have a repository of over 5,000 quality-rated systematic reviews that evaluate the effectiveness of public health interventions. So health evidence is free to use, and you don't need to log in to search our repository. We do invite you to register as a user, and then you can receive our monthly tailored registry updates. So any new reviews that we've added into the registry within the last month, and those can be tailored to your topics of interest. and as well for our monthly newsletter, so you can keep up to date on upcoming events, so our upcoming monthly webinar series and other public health news. We invite you to tell your colleagues about health evidence and follow us on Twitter. We post review-related tweets daily on our social media feeds, so you can receive information about our monthly webinars and any other announcements or events that are coming up. So we encourage you to share this with your organization, and as well, always contact us. Our email is posted at the bottom, and you can suggest topics for future webinar sessions or providing any other general feedback. So we'll just move on to our last polling question. If you have any next steps that you're considering, so hearing about the evidence today, if you have any plans to take any action steps, so you could consider accessing the full text systematic review. So again, we had that link posted in the chat section earlier. Accessing the quality assessment rating for the systematic review. Consideration of using the evidence or telling a colleague about the evidence. So you can check any of those options that apply and then hit submit at the bottom on WebEx. So I'll just take a look. I'm not seeing too many more questions, but I know that Amanda had mentioned earlier that we can post, she's happy to receive any feedback or questions, so perhaps we can make sure that your email is available, or we can accept any emails and forward those to you as necessary.
Great, thank you.
And with that said, I'd like to thank everyone for joining us today. That was a really great presentation, and happy to hear everyone's questions, which always help to make it a very stimulating session and engaging for all of us. So thank you for joining us. And if you would like to hear about any other upcoming webinars that we have, you can visit our website. Our link is posted there in the chat section. And just as a reminder, we'll make sure that the PowerPoint presentation, the slides, and the audio recording will be made available on our social media pages. So with that said, I'd like to thank you so much, Amanda, for joining us today. And if you have any final comments that you would like to share.
No, just thank you for inviting me, and yeah, keep in touch. And if people are keen to find out more, they can email me directly.
That's great. Thank you very much, Amanda, and thank you for joining us. So thank you, everyone.